Okay, so we're going to go ahead and get started. It is 2:03 and welcome everyone. My name is Denise Covington and I am the chair of this committee as well as the SAFE program manager. And before we get going, I want to make a couple of notes. One is that this meeting is being recorded and will be available for viewing on the Judicial Branch YouTube channel. That is the second, and the second thing that I need to note is this meeting actually concludes a 4-year term. It's hard to believe, but this term of the SAFE Advisory Committee began in September of 2019, before we ever knew the word pandemic. And so we're going to have this be the last meeting, and in September we will begin a new 4-year term, and we do expect to seat several new members at that time. So welcome everyone. And before we get started on our agenda topics, we are going to actually go around and interview, and I'm going to note that Rachel has said that her camera is not working today, but Rachel, do you have your audio working?
I do, Denise. I'm sorry. I'm trying to sign in on my phone also so that I'll be here virtually.
That's okay. Can you start us off by introducing yourself?
Sure, that's fine. So my name is Rachel Henderson. I am the current Connecticut chapter of the IAFN president, and that's about it. Safe nurse, and I'm happy to be here.
Thank you, Rachel. Brittany?
Good afternoon, everybody. I'm Brittany Kaplan. I am the legislative liaison for the Judicial Branch. I'm in the External Affairs Division. Today, I'm also doing double duty because I'm going to try and stream this meeting. And to that end, Denise, I didn't realize I have to do it in the computer in the next office over. So I'm just going to pop off and I will pop on in a different location very shortly.
Sure.
So I will be right back.
Certainly.
Feel free to continue.
Okay, thank you. Mary.
Good afternoon, everyone. Mary Kazicki, Deputy Director here with the Office of Victim Services. Nice to see you all.
Thank you, Mary. Robin?
So, Robin, I even wore red, so you'd remember my name, Red Robin. Haha. So, Robin Tausieres, Department of Public Health, Office of Injury and Violence Prevention, which includes preventions of sexual violence. And I'm going to introduce our two people who came with me today to help me with what we're working on. First is Shanae Powell. She's an intern with us from the Center for Disease Control Foundation. And she's actually based at Planned Parenthood for us right now. And also Sarah Moriarty, who's joined us a couple months ago as a health program associate and will be assuming some of the responsibilities of the sexual violence prevention program. So I took care of them. 3 for 1.
Well, thank you. And welcome, Shanae and Sarah. And we'll go to Marielle next.
Hi, good afternoon, everyone. Marielle Daniels with the Connecticut Hospital Association.
Thank you, Marielle. Beth?
No. There we go. Sorry. Good afternoon. My name is Beth. I am the ED of the Connecticut Alliance on Sexual Violence. It's good to see everyone.
Thank you. Amanda. I saw Amanda. There you are.
Hi, my name is Amanda Mendoza. I'm also with the Connecticut Alliance to End Sexual Violence.
Okay. And Kim?
Hi, I'm happy to be here. Denise asked me to say a little bit about myself before the meeting started. I am new to the Judicial Branch in the Office of Victim Services. I started about a month ago. It'll be a month this Friday. I'm the new training manager for the sexual assault program. I'm really excited for this position. I've been a nurse for 32 years and I worked in a variety of different acute care settings. And I also taught in an undergraduate program in the state of Connecticut for 8 years. I'm an experienced SAFE nurse. I have a master's degree in nursing education and I love to teach. So I pursued a doctorate in healthcare science with a concentration in healthcare education. And I'm really excited to be on this committee and to help with the training portion of the Safe Nurse program. So thank you for letting me be here today.
Thank you, Kim. Jean, I know you and Robin, so I'm going to ask Jean you to go first and Robin Vincent for you to go after Jean to introduce yourselves.
Hi, Jean Weisbrod with the Office of Victim Services, providing administrative support. Thank you. It's nice to see everybody.
I'm the administrative assistant for the SAFE program. Good to see everybody.
Thank you, Robin. As I said, welcome everyone. And we do have a quorum, so we're going to start off our agenda. We actually have 2 sets of minutes to vote on. The first one being the approval of the March 8th minutes. And I realize that not everyone here was at that meeting. Obviously, if you were not at that meeting, we do ask that you not vote. But for those of you who are here, were there any, let me ask you this. I need, I guess, a motion to accept and then a second before we discuss.
I can make a motion to accept, Denise.
Okay, thank you. And second?
This is Robin. I'll second. My calendar says I was there.
Okay. Any discussion or edits to those minutes? Okay. By a show of hands, those who are here or in the chat, if you can, is this the minutes approved? Okay. And the approval of the May 10th meeting minutes. So a motion to accept in a second.
I'll make the motion to accept, Denise. It's Marielle.
Okay, thank you, Marielle. Second?
I can be the second.
Who is that?
Amanda.
Okay. Okay, again, approval by a show of hands or the chat. Oh, I see Rachel also said I'll second too. Okay, so we have those approved. And now we're going to move on to the update on the revision of the DPH pamphlet. And I expect this will be most of our conversation during this next hour. So Robin, if I may turn this over to you to discuss the pamphlet and the revisions to that pamphlet.
Sure, which is the main reason why I brought Shanae Powell with me, because she did a spectacular job going through the resource list and identifying discrepancies that we need to address. So let's see. Just because some people haven't seen it maybe on this, can you bring it up, Denise?
Sure.
Let me see. The original, not the edits, right?
Or let me ask Shanae, do you?
Yes,
Let's let Shanae bring it up, because then.
Sure. I'll go ahead and share. Give me one moment, please.
Let's see.
Shanae will do it.
Yes, I'm wondering if, because sometimes it's the organizer who can share.
Oh.
Okay. Yeah.
So hang on a second. Let me, if you don't mind, let me see if I can bring it up.
Okay. So just to bring everybody up to the same page, this is a brochure that there it is. This is a brochure that will be included in the packet of information that is distributed to a person who's experienced unwanted sexual experience. Just to make it clear, this is if they've had a safe exam at the hospital, right? They get this packet.
Well, that would be true. I don't necessarily think, and Beth, please feel free to chime in here. I don't necessarily think that it's limited to that. Beth, am I correct in saying
No,
that?
yeah, it wouldn't be limited to that, but I think it would be available for folks. And I don't think it's necessarily something that everyone would want to take. I think it's an opting into what somebody would take as they're going through their discharge stuff.
Okay. So, and this, just like I said, to bring everybody up to speed, this was historically legislatively mandated. So that's why we're doing this. We didn't think of this ourselves. We're following legislative mandate. Please correct me if I don't get any of this right, Beth and others. So this, what we're looking at is a revision of the original document, which was from 2000. When was it? 2000 maybe?
Oh, I don't know.
So
it's a number of years old. I know.
Right. So we took it was around 2000 when the original document brochure was formulated. So we have been working on this version, trying to revise that for about a year now, just to give you a clue. So the document is, let's say, separated into two sections. The first is narrative about unwanted sexual experience and directions to go in. The second part is the list of resources available for anyone who needs to access them. So our last venture with this was that Beth and her group were going through the narrative part to see if any corrections needed to be made. And then, but they felt that any corrections to the resources wasn't within their purview. So that's where we asked Shanae Powell, if she would assist us with going through the resources. Like I said, she's currently based at Planned Parenthood of Southern New England. So this was actually helpful for the coordination of linkages to care work that she's doing there. So I tried to, so I'm not a technical, and thirdly, we have a vendor, a marketing vendor, Converge, who is the one who's actually doing the actual development and the graphics and making it look nice, etc. for us. Lori Johnson is her name. She's not with us today, but we're in contact and she'll look at this afterwards. When I sent her the two revisions, the one from Connecticut Alliance and the one from DPH from Shanae, she was pretty confident that it was mostly text, so it wouldn't be that big a deal. We have a very small purchase order with them to do the formatting and graphics for us. So we don't have funding right now, at least for printing. So that is a dilemma here. Last but not least, anything that gets published with the DPH logo on it has to go through the DPH Office of Communications. So we did submit the current draft to them for discussion, and they came back with a series of comments that they thought would be helpful. So here we are, we're still trying to put together multiple pieces of things into one document. So I would, I've been going through it, and what I would say about the narrative is I think I can do this separately with the Connecticut Alliance, because I wasn't quite sure if the revisions you sent me meant that you wanted me to strip out all the narrative and just put in what you suggested, or if you were just suggesting revisions to the narrative. It's a little hard for me to match up the two documents. So I think we can sit separately and do that.
Beth, are you there? I'm sorry, I can't see everybody at this point because I'm looking at the document. Beth, do you want to have input?
I'm happy to do that. Honestly, our stuff, I think I sent it over maybe in like a Word document, if I'm not mistaken.
Yeah,
it was
yeah.
going over any edits that were to our contact information or the membership information. And then I think there were just a few more broad edits. My guess is we could probably sit together on Zoom for an hour and knock out, like go through that entire list of things that we sent over. So I'm happy to do that at any point if that's helpful to move it forward.
Right. I think that would be simplest versus the whole group wading through the weeds here.
Sorry.
I mean, we'll send it back to the group for revision, but to do this little detail-y stuff, I don't think everybody has to sit through it.
There's also recently been a hotline number change to the Hartford office for the YWCA New Britain Sexual Assault Crisis Service. That was like maybe a month ago that the number was changed. So I'd also just would want to double check to see that the right number is on.
I have that circled in because I went back through this also and it was sent out last week, my guess is. So I have that circled in here to update Amanda. But if there's anything else that you can think of, I'm happy to add that to our list.
Okay, thank you.
You got it.
So, okay, so we can, it's a lot of, there's nudgy detail stuff that not everybody wants to sit through. So, but what I do want to do is let Shanae walk you through the resource pages. I don't know, can you turn over control of the document to her?
I don't know, Jean, I don't know if I can stop, because I think what you have to do is make her a presenter. And I'm going to stop sharing.
Yes, Denise, I just made Shanae a presenter.
Okay.
There we
See
go.
my screen thing?
Yep. So I'm going to let her go through this with you. Remember, we took this from a very old document. And when we started going through the contacts, we realized that many of them are outdated. Many of them don't even offer services for sexual violence. So we at DPH, we don't want to make this decision for you. We need your input as to, we don't think you still want to include all these resources that don't offer services. So, but we just wanted to walk through with you quickly, so that you can see how many of them are basically null and void at this point in time. So off you go, Shanae.
Sure. So I'm just going to go ahead and just show you guys some of the edits that I made. And again, if when Beth and Amanda set up a day where you want to go over this in further detail, I'll be glad to help with that. But yeah, so a lot of this stuff is a lot of just basically some grammatical errors. So just, kind of updating some of that information here. Just some simple edits that we've made here. The department just decided to just, be specific. The Connecticut Department of Public Health. So yeah, so we just, those simple edits, we highlighted those for you guys to see here. But the bulk of the edits that we made were to the resource list here at the bottom.
Can we stop right there though for just a second and go up just a little bit to that section?
Sure. Section?
Or maybe it's the seeking care after the assault. What I had noted was, and maybe it's a little further along. It was, I see, yes, it's because you're on page 4. Can you go to page 5 and 6? Yes, right here. So sensitive, competent care for someone who experienced sexual assault includes testing for STIs, sexually transmitted infections immediately after the assault and during follow-up, depending on what happened. Actually, unless you are in the pediatric population, that is actually not the standard of care. Prophylactic treatment is the standard of care, but testing for STIs immediately after an assault is only going to show what you already had. It's not from the assault, which is one of the reasons we really encourage follow-up care.
I had the same note, Denise. It's down a little bit further, basically. There is a bolded section that says it. I think it just needs to get moved up.
Yeah. Yeah, we want to make sure that we're not, because I did see it, there was a wonderful table on page 7, which I thought really highlighted very well the and it was actually accurate, where it talks about medical testing, and then yes, there it is, the testing time frame. And this actually is correct, and it does contradict the other one. Oh, and Rachel has a hand up. Rachel?
Yes, I was actually wondering how come it wasn't mentioned in the brochure about like the SAFE program and where patients can access safe care, or the availability of that potential, you know,
well, I
trained staff.
I think the issue with that is there are going to be hospitals that can activate the SAFE program, but then there are going to be hospitals who have SAFE trained staff, and we're never going to be. So if we try to capture it, it's going to be hard to be accurate, I think.
That comment actually, this is Robin. That comment actually came up a couple of months ago. Somebody did bring up that there is no listing in the brochure of hospitals that offer SAFE services. So,
because it could be virtually all, or it could be 98% of the, you know, we know the definitive ones that can activate the SAFE program, but they may or may not respond to the call too. So there's that factor. I think we've got to kind of leave that out of the brochure.
The other thing is just with legislation in Connecticut, I didn't know when I was reading through, it gave me the impression that it was letting me know where resources could be accessed. And I didn't know, I was actually, makes a little bit more sense now to know these brochures are going to be handed out at the hospitals only, like this is a hospital setting brochure, because I didn't know if there was a differentiation that only exams and evidence like medical forensic exams wouldn't take place at any of the advocacy centers or Hope Family Justice, places like that.
The only things that take place outside are children. So the MDTs or CACs in our state, which 2 of them are housed within one of our member centers, but it's totally separate funding, separate staffing, all that kind of stuff. So this would be pertaining to adults. I mean, there is some child stuff in there, I think, but it would largely just be used in that setting, or in a setting when somebody is coming to us saying like, you know, I have immediate concerns about this, and we would give this to them as information, but generally be immediately following a victim who was assaulted, and this would be immediately following.
thank you. I mean, everybody will never get everything in here, but it needs to be as accurate as possible. I will say also that our communications office encouraged us to make it as electronically available as possible, with certain sections that we can change as needed, because it'll be out of date in a heartbeat.
Can I ask one question that's related to all of this, though? So one of the things we've started including for folks is information on how to get emergency contraception. And I wonder if that's an addition that we could put here. I mean, you know, generally you could search on 211. We could talk about Planned Parenthood being that place. But I wonder if that can be put into that chart that's on page 7. So it's about, knowing if you're pregnant now or 2 weeks following. I wonder if we could put something around access of emergency contraception and how that would interact with, the assault.
We can add anything as long as there's space, and right now there's plenty of space. I think I'm trying to read the note that I put in there.
Robin, it
So-
might be worth noting to folks that there's little text above the yellow, and the text that you're reading on the right-hand side is linked to those little, I don't know, logos or whatever you call them. They look like little sticky notes, to be honest.
Right, the
yeah.
comment
The
boxes,
comments,
yeah.
Yes.
So in that comment box, if you can read it, it says, this is my comment, timeframe parameters seem vague compared to text in the brochure. So any tests you had at healthcare facility after your assault will only tell you if you were pregnant or had an STI before the sexual assault. So I think this is the information you want to have in there. A follow up with your healthcare provider in 2 weeks to be tested again will be helpful in making choices for your future. Is that adequate, or do you think you want to actually say emergency contraception?
If it were up to me, I would choose to be explicit about how somebody would access emergency contraception. But the group might feel differently. I mean, that's something that we're seeing more and more, that folks are wanting more explicit information included about that in our stuff.
And it makes perfect sense, since this brochure would, in fact, it be for that purpose.
Mm-hmm.
Okay. Okie dokie.
All right, moving further along.
So, I mean, I can comment for some of on the comment boxes, some of just the language. Do we want to be consistent about where it says provider? Do you consistently want it to say healthcare provider? Or is that not relevant?
I think consistency is amazing, and you should keep it consistent.
So healthcare provider,
Yes.
or sexual violence, it's,
No, healthcare provider.
okay. All right.
There were also a few links to different sites, but we wasn't sure if they really correlated to the information that was provided. So there, for this one, the trauma responses, if you click here, it sends you to this website to Exploring Trauma. I'm not sure if this is needed. Should be excluded from.
I think our team included some of those pieces in part just to sort of, it was so much, it is a lot of content in this brochure. And I think it was with the idea of things were electronic. You could, if folks wanted to seek out additional information, it would give them the opportunity to do it. When it's printed, you're not going to have access. I mean, you could look up, right, the website that would be footnoted. Right. So I think it was us trying to just provide more context and information without further weighing down the content here. But I think that if the group says it's not helpful, right, and keep in mind for us, we are folks who add a lot of information all the time. We want folks to add every bit of information that they can possibly have. But if it feels like the group thinks that that is not helpful to put those in there, we can definitely talk about taking them out.
Okay. I mean, like I said, we're not the content experts at DPH, so we're going through with, being the red pen people. But we need to know from you. Okay, Shanae.
All right.
Just stop right there. Beth, in your version, you have a section called Know Your Legal Rights. You have it titled Know Your Legal Rights. I wasn't sure if you wanted to replace this whole section with your section, Know Your Legal Rights, so we can talk about that offline.
Okay.
Okie dokie. And all those little comment boxes are asking, is this common terminology throughout assault versus violence versus, I forget. Can you click on the assault comment, Shanae?
Sure.
Sexual
So
assault.
just be specific. Should say.
Oh, sexual assault versus just assault. Do you want to be specific about your language? So if everybody can, yeah, it's really hard to send this out and ask people to go through it before the meeting, but it helps.
Right. We also have
Okey dokey.
exam, so just be specific, maybe medical forensic exam or, you know.
Right. Just so you don't want to be wordy, but
That is one of the things that stood out. I don't know if Denise, you feel the same way, but the wording gets switched back and forth from forensic medical to medical forensic, and it's always commonly called medical forensic exam, as that's the priority and that's the reason our testimony is admissible and things like that. So
Yeah, yes, and I agree with Rachel, but also with Beth that consistency is important. It's easily overlooked. But I would definitely use the same terminology throughout.
okie dokie.
Okay.
So, oops, sorry. Unknown, sorry, I'm not speaking to you. I'm monitoring my mother's phone. She's in rehab right now. We've got four phones in her house still, or maybe 6, I think.
Oh.
Okay.
This one.
So what's the comment? Resources provider for free and not for sexual assault services. I don't remember why we said that.
Also, I think the more current term is STI versus STD, and again, it's one of those things that should be consistent.
Okay. So, okay. So what we found in the resources is, and Shanae, you can correct me if I'm wrong, many of what we found was they have resources for STI testing, but not for sexual assault resources. So that was just kind of our food for thought there. So here we go, right? Yeah, okay. So one of the questions right here is this the right terminology? Oh, I'm sorry, that's me.
I know it sounds funny, but because we
Service
added a legal
centers.
services team and we have a post-conviction team, the Alliance has programs
Yeah,
which are separate from our membership. So we just use that language to differentiate between the sexual assault crisis programs, or which we call centers, or our internal programs, which have nothing to do with our membership.
so that's my little comment there. Service centers are for cars. I got that from somebody a long time ago about, they were doing a lecture about mental health services, and the guy said they can't be service centers are for cars. So you don't have to, that was an aha for us for the moment. Okie dokie. So here we go. One of the comments right away is, do we need both the Alliance and DPH in here? Because it's the same in both, basically.
I would
I'm not-
take it. I mean, I think that this clearly is the DPH has a role in it, but those are the hotline numbers for the sexual assault service programs. So I would take out them listed under DPH and just leave them as the sexual assault service programs.
Got it. So, I mean, because you can see we've got a lot of, what are those things called? QR codes.
Yeah.
There are a lot of QR codes.
Beth, I seem to recall that you also said, and maybe this is one of the things, the text things that you'll change, that there was a limit about Spanish speaking, that you couldn't do text or chat. Am I correct?
That is correct. So it's our text and chat lines are in English only. So we make, we have noted in our edits also, but we make that differentiation after English that we put in parentheses text/chat, and Spanish is still just a Spanish hotline.
Right, that
Okay.
was in the text you sent us. So I don't know, remember we copied this from the original document. So right in the beginning, we have Planned Parenthood, Yale New Haven Hospital.
Robin, and you and
Yeah.
I talked about, when we met last week, we talked about Yale New Haven, that med van,
Mm-hmm.
that was not up to date.
Right. Yep. That's one of them. So
There was,
just first of all, the name for Planned Parenthood is Planned Parenthood of Southern New England, unless you want the people to be able to access any Planned Parenthood anywhere they are. I'm not sure.
Yeah, I'm not sure if that is if that's needed as a resource in the section here.
So, I mean, it's up to you guys if you want National Planned Parenthood or Planned Parenthood of Southern New England.
What I would say is list Planned Parenthood of Southern New England. When you pull up that website, the first thing it comes up, it says find a health center, and you put in your zip code or state. So it's
Right.
more local to us, right? It makes sense because it's a Connecticut-based document, but immediately when you go to that website, if I'm in New York or Massachusetts or somewhere else, I'm going to go to that website and it's going to get me where I need to go.
Right. So are you saying leave the national?
I would put in the Planned Parenthood of Southern New England.
Okay. Okay.
But
All right.
on that main page, it asks you where you're from, and you could enter any zip code or state to find providers.
So in other words, it actually serves as both.
Right.
Okay. Okay.
But I agree. I think we should list the local,
The local. Okay.
yeah, the local name, like that said. Yeah.
I just put it in the chat just so you can see.
So I have for some reason, there's a young man from, I don't know where, coming to the door of my mother's house. I'll have to excuse him. I'll be right back.
So we can keep going until Robin gets back here. So from what I realized is that some of the resources here is very outdated. Addresses, phone numbers, links needed to be updated here. Now I'm not sure how relevant some of this information is to this guide. A lot of these resources do not offer sexual assault resources. A lot of them are just STI services. So I'm not sure if you guys wanted to, add that or.
So I actually did speak to Robin about this. It's confusing when we have the advocacy centers and STI clinics kind of grouped together. And going back to the statute, this really was intended to be more about STIs. And if what the old one listed in this section. It was limited to HIV clinics and STI clinics and what services they actually provided. But I see the value in having both, but I would definitely separate both, because if I'm a victim of sexual assault and I see a place that's really close to me, and I think I'm going for STI, but they don't offer STI, then I'm going to be confused as to why that was in there. So I think both have a place in this, but both should be clearly separated from each other.
So you want separate lists for STI and sexual violence?
STIs, this really is more of a, kind of going back to the statutes. And I'm sorry, I don't have it in front of me, but it was really intended to be for HIV prophylaxis and treatment. And when I looked at the old one, and I don't have the old one in front of me, but I looked at it quite recently, and all of it is just lists simply STI clinics and what services, very specifically what services were available there. And this, what I observed to Robin, was that you had a sort of a mix of the two, where one did not differentiate from the other. And I'm seeing folks in the chat.
Denise, I just added that statute, and I was asking that question. Is this the brochure that was referenced in that statute for utilization in the courts as well, to be distributed by the clerks?
Yes.
Okay, thank you.
So we're just kind of sort of going back to the statutory purpose of what it is that we are doing, which is what Mary put in the chat. So I think it's, information for and services for victims of any unwanted sexual experience or sexual assault. Absolutely. Those services would absolutely and clearly include all of the Alliance's member centers, but I would list those separately from STI clinics. That's all I'm saying.
Okay. I gotcha. We have to go with the legislative mandate.
So pretty much just keeping the existing information, but just, separating the STI resources from the sexual assault resources.
Yes.
I also wonder, though, one of the things that constantly happened with this sort of year after year is that, and this is going to continue to happen, is that places closed or they became, they merged into new agencies, things like that. The link that I sent is like when I go to the DPH website, there's a link, and I don't know how, this would be a question for DPH, how often or regularly this is updated. And we now sit on the statewide, it's like called Healthy Sexuality, but it's all just STIs as Department of Public Health works on it. If this is an ongoing list that's updated by DPH, my suggestion would be, rather than listing all those organizations, because this is the part that like becomes cumbersome year after year to try to go back and update, we simply put a link to, if this is the right one, I don't know, again, we'd have to go back to that section of DPH. We put a link like this in that says, to find your local provider, go here. And that we're not going back in and updating, because it's also just, if you're listing all those, it's a lot of information versus the QR code or saying, all right, go to this site and try to find the closest place to you for the STI testing. The other thing I want to bring up, sorry, go ahead, Robin.
No, I just, when our communications department reviewed the document, their suggestion was, I think I said this earlier, that you want to be driving people towards a website to look for resources versus listing them voluminously. So that was just their recommendation, food for thought for all of you. So just like Beth said, versus listing all of them, decide on a website, Connecticut Alliance, that you want people to be focused on and driven to find these resources. I mean, I guess we could also define the sexual assault. Is that inclusive of STI and other
it's not always pregnancy testing, if that's what you mean. They're not mutually exclusive.
Okay. So but I guess first to decide, do you want all this list versus a website that people will go to find the list?
I think if there's a link, and this is what I think everyone's talking about, Beth, Rachel talked about it being an excellent idea, and you, as everyone's talking about a single link that if you click on it, number one, it works, and number two, it's accurate in the information it provides, and it's always kept up to date.
Well, would it be effective to just add the link to the Connecticut Alliance?
We don't keep a list of places like that, so it would not at this point be helpful to add us. I mean, I think if somebody called us, we can, individual advocates or somebody could use the hotline to get that information for sure, but it's not like we don't keep updated lists of STI testing centers on there. I found that on the Connecticut DPH website. I don't know if that is helpful in terms of like if that is updated or not, and I don't know who to reach out. There's not like a contact listed to reach out to find out who does it, but maybe that's something we can work together on.
Sure. I mean, in our HIV department, there's a contact person.
Well, not for the STI portion, but for the sexual assault resources.
Oh, yeah. Yes, exactly. Okay. I'm sorry. I apologize. I misunderstood.
Okay.
So who will be the sexual assault key?
I think what you have here is perfect in terms of accessing us and our hotlines.
Okay.
The only other thing I wanted to just quickly say before I forget is when you all were talking about, and Mary, thank you for bringing up the HIV testing. I see that as fitting very securely under the Know Your Rights. Like there's a section for victims to know their rights. It's one of their rights. I would not, however, I'd be really, I would be brief in the way that these are listed, because one of the challenges with that is that there is not a, as we found out very clearly many times as a coalition, there is not a single point person to direct somebody to request HIV testing. Like it usually you'd have to talk to the prosecutor, you would talk to folks who are working on the particular case, but there's not like a place that you would go to send everybody to require HIV testing for the offender. So I would just list it and maybe that statute under the victim's rights, which is on page 9.
Yeah. That's a good point, Beth.
Okay.
Pretty much it. So kind of just, organizing these resources, differentiating.
So, we're going to, let me just clear, we're going to drive people towards the DPH website that will direct them to the STI testing sites.
Yes, that in combination with Planned Parenthood, I think you're going to meet most people's needs, right, around sexual and reproductive health would be my guess.
Okay. So are we calling it sexual and reproductive health, or are we calling it STI?
It's not, thinking about the audience and the statutory mandate here, I think we need to keep both in mind, but that's something that I think could be further discussed as to what the appropriate title of that would be. I think the most important thing is that it be a reliable working link, because so often we have these links and I try them. I've tried many links in testing things, and I find that they no longer work.
Right.
So we want to make sure that that's that we're driving them towards something that is reliable.
Right. Oh, absolutely. Okay. So this list of resources that we're looking at will be transferred, hopefully. Well, I guess we need to look at the DPH website, get in touch with their STI person, to see if it's all incorporated there before we cross all this out, right?
Yes, I would definitely, and Beth, you can chime in here anytime. I would absolutely keep this in play until you have an appropriate replacement.
Okay.
One thing I'm a little, I am not an IT person, and I have looked up the technology for QR scan codes. I know that this does have QR scan codes in them. I have read about multiple layers of QR scan codes, and apparently there is a limit as to what you can do. Like if you QR scan code something that also has a QR scan code. There's your camera is not going to be able to function that way. So I think we need to be mindful. We're talking about links, and I think links, the URLs are the way to go. I used to think QR scan codes were the way to go, but it appears that there's a limit as to what can be done with them.
Is there any problem with using both? Like listing the link and then having, like, the way we use them now is we use an updated, I don't know if it's called an app or whatever it is, that it's like we can go in at any point to that QR code. So if a website changes, we go and we update the link in the QR code itself. Okay. So we never kind of have the issue of it, you know, going out of date because we can take care of it ourselves. So I wonder if there's an ability to include both the written out link, right, that I would type in if this was printed and handed to me, as well as a QR code for some folks who might just want to have that really quick, easy access to it, and then save it in their phone, throw this away, or you know,
yeah, it sounds like
later.
Absolutely. If we could do that, that'd be great. Like I said, I'm not an IT person, so my knowledge of what the abilities are is quite limited. But I just know that we also have to keep that in mind.
Right. I mean, we need to be accessible to everyone. So we do need to keep that in mind for sure. So I'm just, when you hand this to somebody after a SAFE exam, do you have some idea of what happens to it?
I mean, do we do any of the information that's there? Some people are going to hold on to it. Some people are going to put it in a drawer and not look at it again for a long time. Generally, folks want to save the tracking information that they get that comes along with it. But I think that it will be a combination of folks holding on to it, and you'll have some folks that just don't want those reminders, don't want to hold on to pieces of paper that are describing the worst thing that ever happened to them. So I think you'd have a combination of folks that would really hold on to it. And some folks, that's my hope with the QR scan, is like, I could scan something, save it in my phone for later, right? And then come back to it versus having this, or if I'm assaulted and somebody at home does not know and I don't want them to know, right? I don't want to bring things like this home with me.
Right. So I'm just thinking of the volume of the document. If it needs to be, the print version needs to be this voluminous. Because how many pages is it?
20, is it 20?
Yeah.
Or 8 and 19 and my paper copy is 19 pages.
Right. So just have to keep that in mind.
One of the things we talked about doing with it, though, also, which I still think we could easily do, and we've gotten a bunch of these ones that are like postcard sized for our like not survivor experience, like a client feedback type survey that we do at the Alliance. We got them printed for like 3 cents a piece, but you could do something that was also an abbreviated version, right, of this, have this also readily available for, you know, folks who want it, but the printing cost could be much smaller if you were printing all, you know, some of the information or some of the links were saying, go here for more information about the following. I don't know if that's doable or not, if there's constraints on printing, because I imagine it will be. I mean, you're going to probably spend, you know, at least $1.50 or more to print what I think will end up being 12 pages.
Do you have an example of something that you're talking about that you can?
I don't in front of me because I'm not in the office, unfortunately, but I can scan. I'll be in the office tomorrow. I can scan and send you what I mean, which are just postcards. They're double-sided, full color, that just we give to folks to say, hey, we want to hear from you. We want to know about your experiences. We want to know what worked and what didn't. I think you could do something really similar. There's enough room on a postcard to say, for this purpose, you know, if you're looking for more information, here are all the resources that can support you. Go to this website to get more information. Maybe in combination with printing them, so that if we did not have the right amount, you still would be able to give something to everyone who came through.
I like that idea, Beth. Is the QR code also on that as well?
Yep. Everything we do, honestly, as a coalition now includes both like a the link like Denise was talking about, the written link that I could type in, and we also use the QR codes just because we find that folks use them a whole lot.
Yeah. I'm just gonna chime in here and say Anne has her hand up. And welcome, Anne.
Thank you. Sorry I'm late. I was in another meeting, and but what I'm showing is you guys have this for the law enforcement thing. So could you put the information on a like a thing that holds it all together, and then they can flip to whatever particular page they want? Because I think when you get, I don't know how, if it's on a ring, right? When you leave, if you've given a lot of paperwork when you leave a hospital, you fold it up and stuff it in a pocket or a pocketbook or something. But if you had something that was like smaller that you could put on a ring, then that's easier to carry. I don't know. Because I came in late to this discussion. I'm not even sure what paperwork we're talking about. I'm thinking it's the victim when they're leaving the hospital after the kid. Am I right?
The only challenge for those is the cost, and those were ridiculously, I mean, they were probably like $5+ a item to be able to, so the cost, my guess, would be prohibitive, but I like the idea of it's more durable. We used to print stuff when I first started in this movement, everything was printed on waterproof paper. And that was kind of the way that we made sure that it was durable, and that kind of stuff. So it might just be cost that might be prohibitive.
Is it front and back or single-sided, the 20 pages?
It's front and back.
Yeah.
It's a 5 by, I think it's a 5 by 8. Is that, I forget. It's small and folded. It's not all just 8 by 11 pages.
Yeah. It's hard for people to, when they're going through everything else, to remember to keep that, but it's, at least it's substantial enough that you're not just going to throw it away. So you might put it somewhere where you don't look at it all the time, but if you need it, you can go get it. And all the information would be there. So it's important to give the information, right?
And it's pocket size too, so that's pretty cool.
Right. Well, and I just, in a moment of crisis, I would think you want the person to have, one place that they can think of, that they can call or go to. Yes. So what do we want that to be?
Well,
I could do both.
Yeah, I think what we will end up with is multiple formats of this, but it seems like the first thing that needs to happen is that the two groups, DPH and the Alliance, would get together and combine, finish all the text formatting, and not the formatting, but the content, which I think is pretty much mostly narrative. Am I correct in saying that, Robin and Beth?
Sure. Yeah, that's fine.
Okay. And then once that is done, perhaps what we could do is we could send it out one last time, because I do think that we need also a separation, like I said, of the clinics and the services. And then we can look at the different formats. And one of the things, and I am going to, because it's, this is a wonderful meeting, and we're already at 3 o'clock, and I do want to touch on the next thing, which is actually relevant to this, and it's a part of the discussion, is having that statewide discharge packet. This was intended to be almost the centerpiece of it. And so Robin, did you have any more that you wanted to share with this?
No, I just want to keep people up to speed on where we're at and what we have found. Shanae's been very helpful in terms of going through all those resources to discover for us that most of them do not have sexual assault services. Mm-hmm. And seemingly we're scripting this brochure for sexual assault. So food for thought.
I don't don't think that's a conflict, though. I mean, when we're working with victims, right, they understand that we can't provide every service that they might need. And so I think that telling someone, hey, you know, STI testing or getting some other reproductive health care or other kinds of medical needs met is going to be really expected by those folks. Like, I don't think that it's out of sorts to have those other resources there, because I don't think the expectation is that sexual assault programs provide medical care, this kind of medical care on top of the crisis services that we do. I think it makes a lot of sense to have all that together.
Okay.
And you guys are
Just-
kind of like the concierge, right? Like, so people go to you and then you can
I've
say to
never
them,
heard us referred to that way, but I'm going to start using it now.
I stole it from somebody else. You know, like one person, right? Because whenever you have, like, if you have cancer, they tell you like one person that can walk you through everything. And if you know, even if it's the information about, because there's phone numbers that people can call and they don't work, right? So that's why we have a lot of people calling the police that don't need to be calling the police. But I think if you guys are the concierge service and you can walk them through, here's what's in the rest of the booklet, and that they feel comfortable enough going back to you if they have a question about, maybe it's not a service you provide, but you can say, oh yes, we know the people over there, and you can sit with them when they make the phone call.
Mhm.
I apologize for interrupting.
No,
We'll
yeah,
get
that's
you,
exactly right.
We'll get you a uniform and a hat, and we'll tip you.
They might take it, honestly. At this point, they might work for tips because we're not able to pay them as much as we need to. So,
Okay,
So-
so I'll set up with Beth's group to go through the text, and we'll look at the DPH website for STI sites. We
do
did
you,
have,
Robin, work with it's called the Healthy Sexual, Sexual Health. It's under DPH. It's like a whole separate. We thought it was like more comprehensive, and what it is really is focused on is STIs in the state. Do you work with them?
well, we have a whole unit devoted to HIV, STI, so I mean, we work closely with them. But I think there's another group that seems to be emerging. I'm not sure if that's who you're referring to, or our HIV unit.
Sydney Jones, it's assigned to Hartford. They are the career epidemiologist field officer at CDC, but they're assigned to Connecticut. That's who sends us a lot of the stuff about the meetings. Jesse, one of my colleagues, attends the meetings, but it's called the Connecticut Sexual Health Coalition. But it's run out of DPH.
Yes, I think I'm blanking on her name. I know that they started up, but I haven't been in contact with them. So
Arlene Lewis, that's another person who's involved.
yeah, yes. So we had them look through the brochure. They gave us some recommendations, and we'll pursue that with them around listing their website as the main resource. So we'll drive people to that.
Yeah, if they're in agreement, and that would be great if we could make this as simple as possible and have a single source to drive them to.
Mm-hmm. Okay.
But at the same time, the information that's in the pamphlet, I think that information is really invaluable. So I don't want to take away from that in doing so as well, but just make it a part of it.
Sure. No, we wouldn't take away. And we also have to consider, from the State Department of Public Health, our mandate is to meet the needs of all the residents of the state of Connecticut. And, that has to do with all kinds of issues. So, we're going to be asked at some point, is this brochure appropriate for this group and this group and that group and this group? So just something for all of you to keep in mind, because we serve everybody.
I think, though, that you could simply go back to the statute on that Mary has in the chat, because that gives you your mandate there with the brochure.
Right.
Robin, I think it's Linda Ferrero from the Connecticut.
Thank you. Yes, I should remember that. She used to sit next to me. We got reorged. That was like 15 years ago. Okay. Yes. Thank you. Thank you, Shanae.
Okay,
Okay.
any other questions about it? Thank you for such a robust conversation. It's been great. Any other questions? Okay, there are a couple of other things on your agenda. One of them is the update on the statewide discharge packet. And all I'm going to say is that this was intended to be, as I said, almost like the centerpiece of that discharge packet. And as I mentioned, the idea had originally been to have a QR scan code that would lead to different web pages and resources. And in a previous meeting, we had not only included the DPH packet, but also information from OVS, from the Alliance, Safe Connect from CCADV, as well as information on kit tracking. And one of the other things that I had intended to bring up, and it will be under new business, but I'm going to introduce it now, chair prerogative, because it just simply fits right here, is the idea of redoing that victim survey. And Beth, you and I had a conversation before, and I'm just going to share very briefly, if I can bring it up. Does everybody see this?
Yes.
This actually was last updated in 2015. This is the current, and this is program. But this is what is currently in use in the SAFE program. And there's a back page that has some resources on it. So with the September meeting, as part of, and I'm going to stop sharing here for a second, and as part of the discharge packet that will go along with the DPH pamphlet and the other information, we want to redo the victim survey. And it will be, we're going to hand this to the new, when we seat the new term in September, we'll begin work on that. And hopefully we'll get it done in short order. It would be lovely if we could start 2024 with a wonderful statewide discharge packet with the DPH pamphlet and Alliance pamphlet, and figure out how to get this into the hands of victims in a way that makes it simple, and that also allows for local resources. Does anybody have any thoughts or ideas or questions on that?
I do, Robin here. Just when you were scanning through the survey, there was a question in there that popped up for me, because it says, did you report your incident to the police? Every year when we report back to the CDC, we have to report a number for that question. And Beth, I've been over this with Jesse. That's a hard number to get. And so I'm just wondering, so we're getting our number from Jesse and from the Alliance. I'm just wondering if that survey gives us different data back on reporting your incident to the police.
So I want to make two clarifications just for you, Denise, that we have each time. So this last was updated in November 22 was the last time. Every time that there's been either changes to the hospitals, like the hospitals who provide the care, or there's changes to that last page of information, which lists our programs, your information.
Oh, okay.
So it has been updated, not substantively questions. So I just want to clarify that there's not outdated information being sent to victims or being given to victims. Robin, the answer is probably not, because we do not get back. I don't even know that we would get 20%, right? At this point, we definitely don't get anywhere near 20% of folks responding. What we tend to get are folks who had really great experiences and they want us to know how great the advocates were, or most commonly, to be transparent, they have really poor police interactions and they want us to know that. That tends to be the bulk of what we get on these. But I would say we honestly get a handful each quarter. It's not a lot, so I don't think it'll give you the kind of data you're looking for in terms of who is reporting and who is not. I'm guessing most that you get that most accurately from, Connecticut Police, really, and from the Uniform Crime Report, which again is always going to be underrepresented of probably even really who does report to police, because police don't take everybody's, don't follow through with everybody's reporting of sexual violence. So I don't think it'll probably give you more data. It might give you additional data, but I don't think it'll give you the scope of data you might be hoping for.
No, that's concurrent with what Jesse has told us, that the numbers are not that high.
Rachel, you have your hand up?
Yes, I was hoping with this being, a statewide thing, is now the victim survey going to be distributed to all hospitals within the state of Connecticut, regardless of if they receive SAFE program care? I think it would be great if it was, but is that?
No, this was intended to be a statewide. What we're talking about doing, along with as part of a statewide discharge packet, is doing a victim survey that would allow for us to have a better grasp of, where the gaps are in service across the board. That was just simply a sample of what we had been using. And clearly it's very, in my opinion, it was great for the time, but it's outdated. And if we're going to do a statewide discharge packet, part of that, it makes sense. Part of that should be an effective victim survey that would allow us to know, or to have at least a better understanding of what it is we need to, what is it that we're doing right, but also what it is that we need to improve on, whether or not SAFEs are involved.
Right, so it'll be across the state. It'll be all patients, all
yes
hospitals.
Yes.
That's great. That's awesome.
Yes, and so that's going to be a project that we're kind of basically handing to the advisory committee to work on. And
that's amazing. It's going to give you the data you need to show that you need to get SAFEs more places. That's exactly what you need.
Yep. So any other comments about that, about a statewide discharge packet? We're really going to be introducing that more as new business with the September meeting, but I really wanted to kind of sort of tie that in with the DPH pamphlet, since that would really be the centerpiece. So any other comments about that? Okay, we have a few minutes left. I'm actually going to ask Kim if she could simply give a brief report on basically an update on how the annual competency day is going.
Sure. Can everybody hear me? I guess. All right. So I'm beginning to take over the annual competency day training. And I'm not sure if everybody's aware, but the annual competency day is a mandatory annual training for everybody. All the SAFEs have to complete that in order to maintain their SAFE certificate. So in order to accomplish that, we set up 9 different training dates. We had 5 in June, 1 in July, and we have 3 that are going to be taking place in August. And then additionally, we're looking to set up 1 or 2 more in the month of December, so that we can capture all the nurses that had an emergency come up where they couldn't come to the meeting that they actually signed themselves up for. And we're pretty happy to report that most of the SAFEs are accounted for, and we're only waiting for a small handful of people to respond back to schedule their date. So we're happy about that. And I will have more accurate numbers in September when we have that meeting. During the training day, it's a long day. We start at 8 o'clock in the morning and we don't finish up until close to 5 in the evening. And we start off talking about legislative updates regarding sexual assault. And then we discuss the International Association of Forensic Nursing 2018 guidelines. We spend a lot of time going through the state of Connecticut technical guidelines, And we also included a review of the recent memorandum regarding what to do if there wasn't a purple top tube available to do the known DNA sample. Then we send everybody to lunch, and then they come back after lunch, and we spend the rest of the afternoon dealing with the CT100 kit and the CT400 kit. So we do a review of triaging the considerations for when you would do both of the kits. We do evidence collection. So in that, we discuss the 12 steps, and then we do skills validation. And we do skills validation on different things. So we do sample collection of the swabs. We have everybody show us how they would accurately do a smear. And then we also take out the Womeken mannequin, and we have everybody do a genital assessment, collect samples, and then do a speculum exam. We also talk about discharge considerations for the patients, and then finally how to do the transfer of evidence with the chain of custody. And then we wrap up the day at the end, answering questions, and then review with all the people in the room what it takes to be a trainer in the SAFE program, because we're looking for SAFEs to actually help train in the community, like at hospitals and for advocates and the emergency medical system. So when we talk about that, we do have a lot of interest. So we're hoping to get people that are interested in doing it so we can actually train them and then move forward. So that is kind of the nuts and bolts of what's going on with the program.
So this is Robin. I have a question. I always have questions. So annual competency day is for SAFE.
Right, so all the SAFEs, the ones that are in the SAFE response program, as well as the SAFEs that are practicing in hospitals.
Okay. Is there, just so I can keep, I keep everything. You should see my house. So is there an agenda for the day or a curriculum list of topics that you can distribute, just so I can say this is what they get trained in?
Sure. I mean, we have an agenda. We can send that to you.
Right. Just so I can, if somebody asks me, what do they get trained? What do they get in their training? Yeah, I can say here.
So Robin, I'll pop in here. That's part of Public Act 19114. It's part of, it kind of sort of that Public Act statute sets up a, shall we say, a mechanism for keeping and maintaining a SAFE certificate, and it is really guided for those who are not in the SAFE program. It was actually the SAFE Advisory Committee 4 years ago when it was first in play. That was one of the first things the SAFE Advisory Committee actually did, was to set this as the mechanism and determine it was an annual competency day. Originally, it was going to be limited to June, but we quickly learned June was not going to be sufficient. So now it's across the summer. It's across the summer months. We set a number of dates, but they are statutorily required to maintain their certificate through a certain process that the SAFE Advisory Committee actually approved.
Okay. I feel better now.
There you go. Any other questions? Okay, we're actually going to not get into a discussion about program expansion, other than to say, and it's a kind of a reiteration of what has been said before, is that there was no intent of having a statute that sets up a SAFE response program that's only in 8 hospitals. That is not at all the intent. So I know that Linda, before she retired, she was working on budget revisions that had expansion in mind. I can tell you that we are currently in the process, looks like we're going to have 15 in the class for the SAFE program, which is probably close to half the class. We are seeing larger numbers than we've ever seen in terms of applicants and interest, which is a great thing. It's what we really needed in order to expand. So I'm not really going to further elaborate on that. And particularly as we are in the interim, as you all know, Linda Cimino retired June 30th. We do not currently have a new director as yet. We're kind of waiting. So I think it would be more appropriate to wait until December, excuse me, not December. December is when I'm retiring. Little Freudian slip there. We'll wait till September when we next meet to have that discussion and have a little bit more robust discussion on that. And so I'm going to open it up to any further new business, and new business would be, yes, Rachel, with the exception of saying a yes, that's correct. Rachel takes note of the fact that those who do not have to do the annual competency day are those who are board certified. That was also an agreement signed off by the Chief Court Administrator after the SAFE Advisory Committee made that recommendation. And so SAFE Advisory Committee does a lot of great stuff. But we're going to conclude the meeting. Does anyone have any new business they would like to bring up? And this is new business would be work for the committee. Okay, and hearing nothing. Any final comments or questions?
Just
Thank you for working on the brochure.
Yeah, just a productive meeting. So thanks, everybody.
Yeah, thank you all. Really, really appreciate the discussion. And so we're going to adjourn the meeting at 3:25, and we will convene our new committee on September 13th. And I know some of you will be there. We look forward to seeing you.
Bye, everybody.
Thanks.
Bye, everyone.
Bye.